Hello there. This is part 6 of looking at the interview between Daily Mail journalists on a podcast and Dr. Dewi Evans. And the focus of this is on baby D, or child D. I'm just going to play a little bit of the podcast here for this section.
It dawned on me after the fourth baby that there was something seriously amiss here. Now, the fourth baby was a full-term baby, and she picked up an infection from her mother. They were a bit slow to start on antibiotics, but she was on antibiotics at around 4 hours of age, and her response to antibiotics was absolutely fantastic. Within 24 hours, she was breathing more or less on her own. She was needing hardly any additional oxygen. She was well on the mend. And suddenly she crashes. And she crashes several times. Now, this just doesn't happen. If you have pneumonia and treatment is unsuccessful, you will get a deterioration in that baby over a matter of hours. In other words, the oxygen requirements will increase, heart rate may well increase. You will need to give more in the way of support, but they don't just collapse. And in this particular baby, there was evidence of pneumonia on post-mortem. The pathologist described it very nicely as dying with pneumonia, not dying of pneumonia.
That's the section in this interview regarding baby D. I think it's the only section that what he talks about earlier. He says about the first 4 babies, but he's gone into the first 4 cases that he looks at, and that's when he begins to, for him, see a pattern. And that's the specifics there of what he's how he's describing it. Now, what I'm just going to pretty much solely use as the source here is Dr Scott McLachlan's Law, Health and Technology newsletter, his Substack, and it is LL, as Lucy Letby, Part 8, The Death of Child D, and the subheading is, had she been left or resumed on CPAP for the aiding breathing, she might be alive today. So I'm just going to run through this a little bit, not reading it all out, because the main thing, one reason I'm doing this video is to point people towards this particular Substack article, to read it through. Had to look up a lot of medical terms, but I'm doing it quite a lot lately, so some of them are sticking in, and now and again I have to look them up again. But it's so clear that how Dr. McLachlan writes this, and his conclusions are very startling, and compared to what Dr. Evans there said, where he's making it out as though this baby, there was a slight delay in the antibiotics, but everything was fine, everything was great, and that's mirroring it's mirroring what the doctors and the consultants and some of the nurses, especially one of the nurses, is doing as well here, all in contradiction to what the notes and the signs that are happening to the baby, the changes and the struggles the baby's having all the way through it. Evans is simply mirroring that disjunction between the reality of what's happening to the baby, the journey it's going on, and just washing over it with the idea that the baby's stable, it's fine, there's doing great, it's responding brilliantly, and there's no problem. So I'll read various little bits out, and then I'll put the link in the description bar for people to go to. That's the best thing of all. But I'll just read out a few salient points that I thought that really struck me anyway. But you'll no doubt find your own as well through it. So it's baby D, the death of child D. There's an introduction part of it really, which covers the dates of the 19th of June 2015, and the 18th, where the mother's waters are broken and she's not so that the midwife sees her, but she's sent home again and to wait the normal commencement of labour. She's back and forth from the hospital, and she's not really being looked after there. She has to come back again, and there's some sense as though they don't know why she's back there. So the mother confirmed that she had come to the hospital the day before, and after waiting some length of time she'd been checked over, and in spite of her own concerns she'd been sent home again, despite being more than 24 hours since her waters had broken. The decision was made to induce Child D, but due to staff being busy, the mother had to wait until a bed in the induction suite became available, so that's obviously stressing her out enormously. She was eventually placed on a ward where she stayed overnight. We're moving now into June the 20th, 2015. The mum expressed feeling very worried and scared and unwell. She was feeling unwell in herself, not in control, and felt that she was forgotten by staff. So this is all the background to it. Evans won't say any of this, of course. She described that it was only after she'd been to the bathroom and had a bloody show that a doctor was called who decided that they should continue watching and waiting for natural birth. He'd review it in 4 hours. Just to say that all this detail comes from Dr McLachlan studying the transcript, and obviously the transcript includes copious details from the medical notes, so that's the source. Eventually there's an emergency caesarean section is done because the baby, quote, appeared distressed, so that would be in the note, the baby's already distressed. And when the baby is born on June the 20th, 2015, the baby requires immediate breathing support. At birth, Child D was described by the mother as limp and pale and struggling to breathe and making a groaning noise. Dr. Evans doesn't say anything about that at all, does he? He's sort of, none of that's there. There's an interaction between the mother, and a paediatrician. The paediatrician says that because the child was born through a caesarean section, the breathing would not be, quote, as clear, close quote. The mother described that paediatrician, who isn't named here, as being, quote, unquote, too careless. He did not appear to her to be inspiring confidence in his abilities. So we've got all these issues with breathing straight away. The mother was worried about the appearance of Child D. Was told by the paediatrician that one of the midwives would assess the Child D in a couple of hours. She didn't want to wait that long, and after the same doctor had spoken with the consultant, Child D was taken to the NICU. So that's the neonatal ward, intensive care unit. Clinical notes show that Child D was grunting, which is a clear sign that she had respiratory problems, and had a dusky appearance when she was admitted at 7:30 p.m. So baby D is put on the CPAP, 40% oxygen. Heart sounds are normal at that point, but Dr. Rylance noted regular breathing efforts and described them as fairly shallow. The plan was to continue the baby on the CPAP and to repeat the blood gases at 8:45. This is an important bit. At 8:20, Dr. Rylance noted that the parents had been updated on the child's condition and that the child likely, quote, this is from the notes, likely had sepsis, close quote, and was receiving antibiotics to treat the infection. Another doctor appears, Dr. Chowdhury, later notes that on moving the baby to the labour ward, she had become blue, dusky. So antibiotics and the CPAP is being employed, and she's also, sadly, she's jaundiced as well. An X-ray is performed showing shadowing consistent with transient tachypnea, tachypnea, I think that's how you pronounce it, of the newborn. Tachypnea of the newborn, TTN is the acronym for that. It's a respiratory disorder that caused by a delay in the clearance of fetal lung fluid after birth, and causes ineffective gas changes in the lungs. I'm reading from the Substack here that Dr McLachlan has done, which are from the notes, which are from the trial transcript. So after the X-ray result, then the child was intubated with an endotracheal tube and connected to a ventilator. I'm not reading the whole thing. I'm just trying to choose salient bits. I think it'd be best if people read it themselves. So then the child is extubated, so the tube is removed, and then is given this neopath, the CPAP mask again. But the breathing does become a bit more regular. Then the mother's spoken to by a female consultant who then describes child D as that she, quote, wasn't great. Then there's an incongruity where there's a Dr. Bruton, a named doctor, says she also speaks with the mother and said he's very happy, and describes the neonate as well. So you're getting these wide ranges of opinion. So not great or wasn't great and very happy. They don't really match up, do they? Later on that morning of June the 21st, they take these tests and they see that there's signs of respiratory acidosis, sort of acid in the system, in the blood or in the lungs there. Respiratory acidosis. There's two types of acidosis here. I think that's something you can look up as well. I've looked them up. It's hard to keep all the. I don't want to sort of describe them off the top of my head, but I think it's best to look up all these terms. But it's a sort of there's too much acid in the various systems of the body, whether it's the respiratory system or the metabolic system. Because it says here there's further deterioration with increased metabolic acidosis as well for the child. Evans doesn't mention any of that, of course. Her perfusion, I think that's where the blood's going to the various, particularly to the tissues, to the capillaries. Perfusion is noted to be, quote, poor. And then a doctor approved the decision to administer further medication. And there's some problems with the umbilical venous catheter. There's an insertion of that and a umbilical arterial catheter, UVC and UAC respectively. The UVC was removed. It was only able to advance 5 centimetres and it should be much further in. And the UAC was advanced 20.5 centimetres, didn't get a blood sample back. Just trying to pull out the bits that they're not in the right position, some of these catheters, but the readings are improved, but it shows that the route isn't typical for this umbilical arterial catheter. So there's some issues about how that procedure's been done. Right, mum and dad visit. Dr. Rylance appears again and notes at 7 p.m. that there's noted presumed sepsis. So you've got an infection there. That's the second time that's been spoken of. The child's feet were purple, but they assume that's because of heel prick tests that were done. But they hadn't done the lumbar puncture for infection to check with regard to infection. That hadn't been done yet. And the reason it hadn't been done, even though that they're saying, Dr. Rylance is saying that child D is stable and handling well, she hasn't done this lumbar puncture because she didn't consider child D stable enough for the lumbar puncture test at that time. So that's another contradiction. There's stability there, and yet you can't do this other procedure. This is a very moving sort of part where the father comes in, and both the mum and the dad, they're constantly asking how their child is, how child D is, how they're doing, because from their perspective the child looks very poorly, and that's a quote from the transcript, and wasn't feeding, looks very poorly, wasn't feeding, and had tubes in her mouth, but the staff kept responding that she's, quote, doing well. And the interesting thing about baby D as well in terms of what we're looking at, is that Lucy Letby isn't the designated nurse. It's a nurse called Nurse Oakley, and Lucy Letby only arrives at about just before 7:30 on that evening. And Lucy Letby is a designated carer on the night, across the night shift she is to do for 2 other children in room 1. So Nurse Oakley is the one is attached to child D as a designated carer. Some notes made by Nurse Oakley. She takes the child D's blood gases and she describes it as satisfactory. She describes child D's circulation as, quote, not 100% brilliant, close quote. Dr. Brunton appears. When testifying, Nurse Oakley says she remembers, quote, being very happy with child D at that point in the night shift, and that child D was only requiring little assistance with breathing and she was stable. But there's issues with Nurse Oakley's testimony, a lot of issues. Move into now into the morning of the night. So it's the night shift going on at 1 a.m, 1:05 a.m. There's this thing about Nurse Oakley is meant to have gone on a lunch break from 1 a.m. To do these fluid chart records. It's a task that Nurse Oakley signs for that she'd done it. But under oath she claims that Nurse Letby must have done it, because she herself, Nurse Oakley, was on a lunch break at 1:14 a.m. Nurse Oakley recorded having done child D's blood gases, which she again describes as satisfactory. I'm moving through some of the points that you can see in detail there. It's a lot to do with who's actually done these procedures and who's signed for doing them, and there's disparity in that in terms of what Nurse Oakley says in the court. 1:30 a.m. Nurse Oakley says she's called to the nursery by another senior nurse and Nurse Letby. Child D is desaturated to 70%, requires oral suction, discoloration to the skin, trunk, legs, arms and chin. Nurse Oakley described that child D's oxygen was turned up on the CPAP machines and child D responded well, so the CPAP is helping. The saturation's returned to 100%, so that's a good sign. She's weaned back onto the CPAP with room air only. She describes that the rash had been resolved. Dr. Newby comes in, orders increased fluids and a number of drugs and solutions. At 2:30 p.m. there's a note saying that child D's observations returned to normal and child D's considered stable after that sort of crash there. Yeah, that's deemed a crash because the second one is coming up at 3 a.m. So yeah, 3 a.m. child D crashed for the second time. Nurse Oakley records in a retrospective nursing note that child D was crying and desaturated again to 70%, 70s, commenced the CPAP again and the child picks up again. There's more medication administered with both nurses, Oakley and Letby, as signatories. So they're working together there. in her nursing note of this event, Nurse Oakley says the doctors believe Child D would need more fluid on board. Fluid chart says to restart expressed breast milk. 3:45, there's a third crash. We've got all those other markers and notes regarding sepsis that Evans never mentions in his what he says about baby D in that interview, does he? He doesn't mention any of that at all, or all the other issues. He just sort of in his almost invariable generalised way, saying everything was going brilliantly. Yes, there was a bit of a delay with the antibiotics, everything was brilliant, but then you hear the parents saying from there, and that was their child, and they were saying the baby was very poorly. But Evans down the line he can just change everything, change everyone else's perceptions with that kind of wash of, which is what some of the doctors do as well in court. Retrospectively, everything's fine, even though the notes at the time is clearly saying that it isn't. So yeah, another crash at 3:45 a.m. in that night. This alarm goes off, the baby is desaturated, becomes apneic. An alarm goes out and doctors are called to the neonatal unit. Neopuff was retrospectively recorded as Nurse Oakley having been used at 3:52. An SHO comes along to assist Dr. Brunton and resuscitation efforts begin. The parents are woken up, it must have been terrible for them, told to come quickly because their child was poorly. They come downstairs, they find Dr. Brunton holding Child D and, quote, trying really hard to resuscitate her. In court, the mother described Dr. Brunton as, quote, quite agitated, and the parents were asked to let Child D go. Resuscitation efforts were ceased, care was withdrawn, and Child D was pronounced at 4:25 a.m. Throughout all the observation charts, Nurse Oakley, who is the designated nurse, she's the one that signed for all the observation readings hourly. Lucy Letby hasn't. And this isn't to suggest that, it's just to suggest that Lucy Letby, she had other babies, potentially up to, I think, 3, it comes later on, to look after. So this wasn't one of her designated babies even. They showed no other signatures are present on the chart, basically, and they showed that while still on the CPAP and up to the crashes, Child D had been taken off oxygen support and was apparently maintaining 100% sats with oxygen. But Child D's respiration rate was also at the extreme upper end of what's considered normal for a neonate. So there's a sign there of something not right. Yeah. It moves on to the section called Questions now, from this Substack article of Dr. McLachlan's. There's a first question regarding the midwife and the original issue with the mum having to go to the hospital, being sent back, and having this extended period where she's getting stressed and worried because natural birth isn't beginning and her waters are broken in a really extended period now. So there's all issues to do with that in terms of the hospital records, electronic health records, in terms of her attendance. So the administration of these records, were they being done? And the second point here, I'll read it all verbatim. This is Dr. Scott McLachlan's report. I'll put the link down below. Why is it that Lucy Letby was the designated carer not just for 2 babies in room 1, so then not baby D, she wasn't just for 2 babies in room 1, but also for another baby up until 10:45 on the night of June the 21st, so that's 3. And really they're meant to be really only like one-on-one with some of these babies, really, one staff member to one baby. It's just a signifier of how understaffed they are there and how stretched they are. And the location of that third baby is unconfirmed. Nobody knows where it was, and neither which room or incubator that he or she was in. I'll read the third bit. Testimony from November the 3rd to 2015 suggests that in spite of a standard protocol requiring, this is important, this bit, requiring intravenous antibiotics be administered to mothers with prolonged ROM, that's the waters breaking, so it was prolonged as well as over 24 hours, due to the high risk of infection because of that. The mother, by all appearance, wasn't given any antibiotics, so that's another failure from the hospital. Further, testimony in court revealed that there was also a 4-hour delay. And Evans, he does mention that 4-hour delay, but he does it very blithely, doesn't he? He just said, oh, it's just 4 hours, and after that everything was fine. But we just read through all the issues and all the several notes regarding sepsis as well, that he doesn't mention any of that. Doesn't mention any of it, obviously. He doesn't query that stuff at all, does he? He doesn't go into it, he doesn't... How does he, what's his methodology for, people have said his reports haven't been published to be accessible by the public. So what's his methodology for discounting sepsis? What's his reasoning? We need to see his workings out, how he's discounted it. 4-hour delay in giving child D antibiotics that were required because it was both protocol, and it became apparent that she had some respiratory issues, which included fluid on her lungs, this poor little baby, and her symptoms were suggestive of infection. All the signs are there. I mean, there's in that part of that recording, I'll play it again at the end, so you'll have it on the beginning and at the end. So this sandwiching this detail, his sort of very loose. He's saying that. I'll carry on with this. I'll go back to that later. You can see what I mean, though. You can see the difference between the detail here and the way he just throws away comments and everything's fine, which mirrors some of these doctors' kind of blithe attitudes, even though some say, oh, it's not great. Another one says, yeah, I'm very happy. It doesn't add up. It doesn't add up, does it? Anyway, fluid on the lungs of the poor baby, and her symptoms were suggestive of infection. What role do these omissions the omissions of the time, the 4 hours gap for the baby, and the lack of antibiotics, particularly because there'd been a long period between the waters breaking and mum giving birth or having it through birth through caesarean section, no antibiotics given. What role did these omissions have on the eventual outcome for child D? There's a section now called conclusions. One of the conclusions is that the circumstances of child D's demise raises questions generally for hospital protocol. I'm reading again from the Substack. Policy and management, tolerance of staff either misdocumenting or falsifying what is critical legal documentation in terms of who gives medication and when and who's signed it. Somebody signed it for someone else because they're on a lunch break, etc. It raises questions for some of the paediatricians and nursing staff, most significantly for Nurse Oakley. She is the designated nurse for child D. Further, as we have seen with child A and child C, child D's story raises significant issues for an honest prosecution. Then it goes on further about Nurse Oakley's testimony suggests that at the very least there was some either accidental or deliberate misdocumenting of events that occurred, either differently than how they were reported or at different times than they were supposed to have happened. Yeah, with the clinical notes being entered to show occurrence at the appropriate time. And it gives the example of that. You can read that part of it regarding, it's to do with administration of medication there. And there's disparities between what Nurse Oakley says in her testimony and what the notes say. And with this sort of potential looseness in terms of signing once you've done, or not signing once you've done certain procedures, because you can't, on the system, you can do it retrospectively, the notes that you've done something, but you can't do it prospectively to say that that you're going to do it in the future, any kind of procedure or test. Yeah, you can't you can retrospectively record administration, but the system doesn't allow you to prospectively record administration of medication. And the dangers of that is, in terms of, there's a clear example here. I should just read it instead of trying to paraphrase it. It's silly. I don't know why I'm doing that. For example, what if Nurse Oakley had actually been on a break and another nurse saw that the medication administration had not been recorded, so there's not been ticked off, and thinking she was fulfilling the doctor's orders, administered, not knowing that Nurses Oakley and Letby had done it prior to Nurse Oakley's break. So they'd done the administration but not signed it, so that somebody else could come along and double it, and that could be a real issue. And for certain things, like Dr McLachlan says here, if it was a bolus of infusion of saline, it might not have such serious repercussions, but for many other medications it definitely could. Then there's some, put the light on a bit. Oh God. Then there's some discussion more about Nurse Oakley and the looseness in terms of the record keeping. But there's an important bit here where it says Nurse Oakley contradicted her own testimony on other points, like when she claimed that the appearance of the rash, and this rash that's coming and going is used as evidence by purpura, evidence of purpura, which is Evans a couple of years down the line saying this is evidence of air embolism, deliberate air embolism. But when it's seen at the time, Nurse Oakley contradicts herself, her own testimony on other points. She claims that that the appearance of the rash had always stuck in her mind, yet in the trial she can't remember any key specifics about what it looked like or where it was on the child's body, and she was struggling to even describe it. So it's another there's ones like with I can't remember the doctor which one it was, but it's this refreshed memory of remembering it, but then having a difficulty of describing what it was like. There's an unnamed nurse here that pops up that's around. The unnamed nurse from room 2 added quote-unquote refreshed memory details in her testimony that were never present in her police statements regarding the rash being reddy brown. As Dr. Brunton had previously and Nurse Oakley's similarly refreshed memory had described, it begins to look as though the description of the rash is something that's kind of evolved, it says here, up to a point that each person's giving testimony in court, that there's been some kind of agreement to come up with that. A degree of collusion, as Dr. McLachlan says here, among the witnesses, which could mean they met up and were given or agreed facts prior to the court to create this story that they all agreed to seeing these, which are then used very materially by Evans to say that these are examples of these are signs of air embolism, this rash coming and going, or whether it's a rash or this kind of blotches, the purpura, as stated. Another doctor, Dr. Thomas, testified that she had been doing a sepsis screen on another baby in room 2 when child D crashed. She believed it had been Lucy Letby calling for help for child D, but she didn't, this Dr. Thomas didn't recall seeing a rash at all during Dr. Brunton's resuscitation attempt. She described child D as having something different, a purple colouring around the abdomen. So there's all different descriptions here, both at the time and in court. Or sometimes they didn't describe it at all there, and then there. Another nurse, Nurse March, also testified differently to everyone else. She claimed to have seen this. She claimed to have been the scribe during the resuscitation attempt, and while no evidence of a written record was presented to support the claim, she claimed it had been Lucy Letby and not Dr Brunton giving chest compressions during the resuscitation. It's like I was saying the other night about medical notes. The memory of what people actually did, it can get very, very changed and have all these different viewpoints through memory. Memory can just change things so radically from different points of view. And yet, and this is all Evans had, are the notes. But obviously he's deliberately avoided looking at many of the things which would take him away from his obsessive drive to have a serial killer at large there. You never hear him mention sepsis. You only hear him mention sepsis when it's in the cases where he can very clearly and easily discount the crashes and the deaths. You know, from the 32 that he saw and reducing them down to 15. So he does it 17 times. And some of those are deaths from sepsis. We can only conclude, we can only infer, because he says, he gives that list of 3 things, doesn't he? Sepsis, hemorrhage, and genetic issues to do with the child. Congenital, that's the word, congenital problems. This is a really important paragraph from the Substack of Dr McLachlan. Yet again, as we have seen with the previous neonates, because it's a pattern, what we also have is the juxtaposition between the gradual demise of a very unwell neonate. And that's what it sounds like, doesn't it? The situation sounds like this. As opposed to Evans's blithe, kind of very generalised, oh, she was doing great, there was nothing wrong, everything was fine, she was doing great with the oxygen, there's nothing. We have a juxtaposition between the gradual demise of a very unwell neonate, while her condition was being represented by many of the staff at the Countess of Chester Hospital as, quote, stable, close quote, well, and not concerning. And then that's what Evans mirrors, doesn't it? He's just backing those doctors, despite all these notes and the contradictions of sepsis being mentioned and the signs of sepsis obviously being evident. This goes to the heart of the theory of the air embolus, you know, and how air might have got into the baby, even if we're accepting that it can be, air embolus can be diagnosed from an X-ray. There's that issue as well. You know, the idea that if it's after 25 minutes, it's not reliable. You can't rely on an X-ray if it's 25 minutes post the death of a child or anyone. X-ray images from June the 21st, 2015 showed child D that had it having subtle signs of a lung infection. X-ray images post-mortem showed that the infection was present, so it's defined as an infection there. There's no doubt about it. But there was air in front of the spine. But this is important, I think. Such air emboli are something that can happen after vigorous CPR, and that's what was happening. There was resuscitation attempts. So such air emboli are something that can happen after vigorous CPR is administered to a neonate. I've never heard yet in any of his interviews, his acknowledging the potential for air to come into the body through resuscitation. But it's obviously clearly a thing, it's a possibility. And if you look at the Substack, there are references you can go to for examples of when that's happened. And there's also evidence, Dr. McLachlan says, of air leak syndrome that occurs in neonates like child D who are diagnosed with TTN. And this is the odd thing, this other expert that's there, Professor Arthurs, he testifies that it was unusual in babies to have died without an explanation. Unusual to see this air there. He said that the particular amount of air observed is consistent with babies who have died with 1, sepsis, which we know the child D was being treated for it, and 2, sudden unexpected death in infants, which appears to be an apt description of a child D's death, or in 3, a road traffic collision. So this is the irony here, even though he's just described 2 clear explanations that fit child D, the sudden death and also the sepsis, he, Professor Arthurs, incongruently goes on to testify that the finding of air was actually consistent with, but not diagnostic of, deliberate air administration. So he's saying, well, yes, it could have been deliberate air administration, but it's not diagnostic of it. But it's also, his final conclusion doesn't make any sense given his own description of the circumstances that can cause such air emboli, the sepsis. And the fact here that it was established that Professor Arthurs admits to never having seen a case of air embolus like this in his entire career, which means he's not an expert in this particular presentation, and therefore his expert witness testimony on this element should have been excluded. I'm reading still. In this particular instance, Professor Arthur's evidence might be possibly characterised as ipsi dixit, a bit of Latin, as an unproven or unsubstantiated statement. But it carried through, and the jury heard it. So all they hear with all these mounting cases is that, yes, it's consistent with. They don't listen to the. They lose the bit that's come before. To say it's consistent with babies who've died of sepsis. They just get onto the theory that's coalescing across most of these cases, except for the insulin ones, and the ones where there's alleged physical trauma, that it's not to do with sepsis. It's to do with he says it's not diagnostic of it, but he says it's consistent with the air embolus. And that's what the jury ends up hearing again and again, because there's no expert witnesses on the other side to really drill, to bring these things out. That's that Dr McLachlan is clearly stating here. That's you've just got to read this as well. I mean, it says here, Dr. Rylance on cross-examination admitted that it was clear that child D had begun to deteriorate when she was taken off CPAP, which suggests that had child D either been left on CPAP or had staff reacted swiftly and appropriately to resume CPAP, child D might still be alive. It's to do with the medical care that was received there, the various failures. Nurse Oakley admitted under cross-examination that there were very clear signs that child D was unwell. We heard Evans, I'll play it at the end again. We heard Evans saying that no, everything was fine, apart from little pause at the beginning, everything was great. In court, the nurse states that child D was unwell. Dr. Rylance states that child's began to deteriorate before these crashes happened. Nurse Oakley admitted under cross-examination the clear signs that child D was unwell. Even at the same time, she was disputing that child D was really an intensive care baby. So it's all over the shop there with that testimony of that nurse. I'll read the final part now of the Substack. This brings me to a final point. This is Dr. McLachlan writing. Being that under cross-examination by defence counsel, Nurse Oakley, the designated nurse, not Lucy Letby, the designated nurse responsible for child D's care on the night child D died, was clearly evasive, sometimes coming close to the point of being argumentative. For example, her arguing with defence counsel regarding Charles D's classification as an intensive care baby before admitting that Charles D was so classified. While most of the nursing staff recalled periods during 2015 of insufficient staffing, Nurse Oakley sought to claim she couldn't remember, even though she admitted she was required to be on one-to-one care for an While she admitted she was required to be on one-to-one care for an intensive care neonate like Charles D, yet on the same night Charles D died, she was also a designated nurse for another infant in a completely different room of the unit. And that's outside of the guidelines. And that shows further that the lack of detailed care in this instance, because they're overstretched, because they're not meeting and this is what came up in the RCPCH report. And that's why they were reduced down to a level 1, because they weren't meeting these essential guidelines for care, because of the paucity of the staffing. She eventually, this is Nurse Oakley, she eventually and begrudgingly admitted that this meant that the care she provided under such circumstances, quote unquote, fell outside the guidelines. So I'll leave it there, and I'll just see if I can play that bit back again as the sort of topping and tailing it with Evans.
And suddenly she crashes. And she crashes several times. Now this just action from her mother. They were a bit slow to start on me after the 4th baby.
This is it.
That there was something seriously amiss here. Now the 4th baby was a full-term baby, and she picked up an infection from her mother. They were a bit slow to start on antibiotics, but she was on antibiotics at around 4 hours of age, and her response to antibiotics was absolutely fantastic. Within 24 hours, she was breathing more or less on her own. She was needing hardly any additional oxygen. She was well on the mend. And suddenly she crashes. And she crashes several times. Now this just doesn't happen. If you have pneumonia and treatment is unsuccessful, you will get a deterioration in that baby over a matter of hours. In other words, the oxygen requirements will increase, heart rate may well increase. You will need to give more in the way of support, but they don't just collapse. And in this particular baby, there was evidence of pneumonia on post-mortem. The pathologist described it very nicely as dying with pneumonia, not dying of pneumonia.
That's odd, isn't it? Acknowledgement of pneumonia. I don't know which pathologist he's referring to there. Is he referring to the original post-mortem that was done by a pathologist at the time, or is this Dr. Marnides? I'm not pronouncing that quite right. There's a Dr. Marnides that reviews the pathologists and sort of kind of basically overturns all the findings, and he's another one of the expert witnesses, Marnides. So is he referring to that one there? I think so, possibly. I don't know. But his summation there of that baby's journey from birth, and yes, there was a little lag. Did that sound anything like all those notes and all those queries for sepsis? Did it sound like the baby had no problems with breathing all the way through it? The mum and dad's perceptions of being very poorly, not feeding? It didn't, did it? It sounds like he's talking about a completely different child. And that's what he's done. He's just pushed everything to the side that doesn't fit his theory. He's got to have the children, the babies, fully stable, absolutely fine, and then they crash for no reason. This is dishonest, isn't it? It's got to be, isn't it? the things I've read out from the Substack, Dr McLachlan Substack, are from the court transcript, which is taken from the actual medical notes. It bears no resemblance to Evans's characterisation of that baby's journey after being born. At all. Doesn't bear any, not at all. It's a decline, and it's a struggle from the beginning with breathing. And he just jumps over it blithely like there was nothing wrong until there's a crash for no reason. Anyway, I don't want to. It's obvious, isn't it, that there's something very amiss, and he's doing that with all of them, all of the children. He's doing it with all of them. Because he, like with the doctors and with their testimony and the nurse that's joined in there is, I suspect, collusion as well, and Evans there, and then the rubber stamping of Bohin and whoever else, this Marinides. I have to look more into him. He's the one that reviews that kind of gainsays all the pathologists, the original pathology reports, and sort of overturns them based on notes again, not having actually done the post-mortem. This is just, but so you've got this kind of, he's reflecting, Evans there, just really what some of these doctors and one of these nurses in particular, Nurse Oakley, is just to give a false impression of the status of that baby's health through that period of time leading up to these crashes. It's just riven with falsehood, isn't it? Lies by omission, lying by omission. Well, it's not. It's commission, lying by commission as well, to say that the baby was doing absolutely great, no problems with the breathing, and the as the subheading says in that Substack, had the baby been kept on the CPAP machine or the reaction been quicker, the baby might have lived. These are medical errors that have been so distorted and covered up and covered over by this agreed collusion that Evans is obviously part of as well, to push all those realities away that are still there in the notes, but somehow to get away with it. To get away with saying all that in court and then telling us that now from his home to the two journalists. Anyway, thank you. Take care.